we don't usually speak to the general public about these kind of complex scientific endeavors, but and it's always interesting to try to explain it to everybody, and I do enjoy that. So I'm very happy to share what Libby was describing and put it in context for you. And I know it's a mixed audience of survivors, patients, family members, and other interested people. This is a really fascinating disease. It's obviously fascinated me through my whole career. And these are the people that I work with. It's a very elaborate group of investigators who spend a lot of your tax dollars and other research funding. And of course, we're very grateful to what PCC has provided to us over the years. And it's a complex world of pancreas cancer genetics. So I'll put it in perspective for you over the next 30 to 45 minutes. And I don't mean to scare you, but this is actually the title that I chose. Is really Scary Lessons. And a lot of it's based on the fact that we're just really starting to uncover the mysteries of this disease. And it's lagged behind other cancers. You hear a lot about breast and prostate cancer, where there are many reasons why the field has accelerated more rapidly, mostly that there are survivors who can provide blood and tissues. There's a lot more money. There's much more awareness. But I think PCC and Libby and others have generated a tremendous amount of increased attention to this disease. And Canada is very much leading the way, as I'll show you, in the field of pancreas cancer research. This, unfortunately, is a slide that you're all familiar with. This is a standard, what we call survival curve. The females are on one line, males are on another line, so this disease does affect both sexes. This is survival from 0 to 100% over time, years after diagnosis. And most people, unfortunately, succumb to this disease, as you heard from the pearls, and that story is repeated over and over and over again, and that's what we're trying to change. And I think there is a lot of hope, as is the title of the symposium. I'm a surgeon, and we have the easier part of the job. The medical oncologists and palliative care doctors have a much more challenging part of the job, because we get to handpick the patients who are operable. So of 1,000 patients who are with pancreas cancer, and there's about 1,500 cases in Ontario each year. This slide's a bit old because the disease is rising in frequency or in incidence as the population ages. I don't think the incidence is changing in terms of the number of cases per 100 or a million individuals, but as the population ages, there will be more people with pancreas cancer. We only get to see about 20% of those in the surgical departments, because the remainder, unfortunately, present with what's called advanced disease. This is an old CT scan. The pancreas tumor is here. It's kind of this fuzzy gray thing, and you can see little strands of tumor cells that are projecting into the tissues. This is actually a rim. The black little rim there is what's called ascites, or fluid, and it's around the liver, and this unfortunately represents tumor cells that have escaped the actual primary tumor into the abdomen and are growing within the fluid of the abdomen. And this is the average patient who unfortunately cannot have surgery, because we can't resect or manage patients who have widespread disease, and that's about 80%. And that's the challenge that we're trying to understand. I'm not going to talk about screening. I can talk about it later if you want, but at the moment, screening is considered investigational, although we are interested in the very high-risk groups, like Libby was describing, and I'll talk to you more about them. But there is no screening test, and we are in the midst of a screening program. But I think, as I'll show you at the end, screening has a long way to go, and we really need to focus on understanding the disease really at the basic genetic and cellular level. I don't think there's going to be a grand slam tomorrow until we start really stepping back and looking at these tumors in more depth. This is, for those who are interested in surgery and history, surgery is always interesting because stories get told and then retold, and it becomes broken telephone, then it becomes legend and dogma. But in fact, the operation that we do, that's kind of the tour de force of general surgery, is called the Whipple Operation, named after a surgeon at Hopkins who took credit for it. But in fact, this guy, Walter Couch, was the one who actually described the operation. And he did it in 2 stages over 2 days. One day he took out the tumor, and the next day he closed the patient up, left all the ends hanging, and then the next day he put things back together again. And again, considering the technology in the 30s and 40s, that was a pretty ambitious endeavor. But in fact, this guy, Owen Whipple, who popularized it more in North America, gets credit for this operation, and he's from Hopkins, or was from Hopkins. In our own area, within Canada, we have a lot to be proud of because people like Bernie Langer and others, this was the generation of surgeons in the 50s who decided to try this operation because up until then, almost every patient was dying from the surgery, not from the cancer. They would die either on the table or shortly thereafter of complications. But Bernie, who was one of my professors, learned how to do this operation safely, popularized it in the 60s and 70s. And then when I was training in the 80s, I was able to reap the benefit of that. And we're kind of the next generation of surgeons. But as I'm getting older, of course, now we're passing it down to another generation. The pancreas is kind of in this obscure spot in the back of your abdomen called the retroperitoneum, which is why it's often silent. The tumors are often silent. It's a technically complex area for surgery with a lot of big blood vessels. And unfortunately, most of the tumors in this area invade these major arteries and veins. And that's just the nature of this disease. It's a technical anatomic problem. And they also spread widely throughout the body, probably through these blood vessels, even when the tumors are very tiny. And that's what we're trying to figure out. The Whipple operation is now done in 10 centers in Ontario, and the provincial government has actually done a very nice job of what's called regionalizing, so the operation is done safely in competent hands. It's not so much the surgeons that are the big show, although we get much of the credit. It really is the team around us. It includes fellows and many other disciplines that look after the patients, because many of our patients have complications, and the patients, in the old days, patients would often die of these complications in the hospital, and our patients are actually rescued by the interventional radiologists who actually drain abscesses and put tubes into difficult areas to deal with many of the problems that we actually cause for our patients. So pancreas cancer surgery is actually pretty safe in Ontario. We have one of the lowest mortality rates, and we think we're doing a pretty good job looking after our patients. And practice does make perfect. This is what are called volume outcome studies. These are popular in American healthcare, trying to attract patients to major cancer centers. The bottom line are the number of cases, and each of those vertical bars represents the number of cases at different hospitals. And you can see for pancreas cancer surgery, what we call the volume outcome relationship is the strongest, meaning if you do a lot or if your center does a lot, then the patients will do better. And it's not necessarily true for all surgery, because many surgeons actually get quite anxious in the community when they're told what they can and cannot do. But in fact, pancreas cancer surgery is not that common. There's only about 400 or 500 cases to operate on a year, maybe less than that. So we really don't need to be sharing them amongst all the surgeons throughout the province. So it's better that it's regionalized, and that's what we've been doing. And I work also with Cancer Care Ontario trying to improve the healthcare services in the province. This is just a gory slide, shows kind of the tour de force of one of the surgeons in our center who's been trying to take out bigger and bigger tumors by reconstructing blood vessels. This is actually a 12-hour operation. It's kind of a masterpiece in surgery because Ian McGilvery was able to remove the tumor and put all these blood vessels together in a pretty elaborate way and in a way that actually very few surgeons in the world can do. So we've been trying to extend the indications and the type of patients that we can operate on, and we call this RCAP. It's arterial resection of cancer of the pancreas, and we've received some funding. I think actually Celgene is helping us. I don't know if they're here, but we want to thank Celgene for helping support this study. We're actually going to be doing this very radical operation on about 30 patients in a prospective way. We're going to look at the outcomes, publish them, and hopefully show that in specialized centers, even more radical operations can be done. But it's a bit misleading. I don't want to tell you that surgery is the answer, because surgery is not the cure for the majority of patients. And Libby is very much an outlier. And there's other people here I met this morning who are outliers, who are terrific stories at a cocktail party or at a symposium. But in reality, that's not the nature of the disease for most people. So it's misleading to say that everybody wants to be like Libby, of course, but the reality is most cases won't end up like Libby's story. In fact, the cure rate of the patients we operate on is only about 15 or 20%. So remember, we're taking 20% of those 1,500 cases. We operate on those, but only about 15% of those are actually are cured or likely to have survived their cancer for 5 years. So we're actually doing very badly. There's very few areas in surgery where the failure rate is as high as 80 or 90%. I mean, it's worse than baseball when you think about batting 300. So it's very hard for surgeons to kind of acknowledge this fact, and we wake up every morning hoping we're doing a good job, but the reality is surgery is not the answer for most of our patients, and even for most of the patients that we operate on, which is why I feel very strongly that we need to kind of step back and try to understand this disease as opposed to just operating more and more and more and not thinking about it. And if you look at the past 20 years of chemotherapy, which is the other discipline that's used for managing pancreas cancer, these are the data. The main drug that we've been using is called gemcitabine, and that's been around for about 20 or 25 years. And the median, that means the average months of survival is only about 4 months. That was before gemcitabine, then gemcitabine in 95, and then there's a couple of new cocktails that are pretty exciting, but they really provide just a small, measurable, statistically significant difference, and patients are living longer. We're definitely seeing patients living 2 years that years ago was actually unheard of. So a survival of 2 years now with advanced pancreas cancer is possible with these new drugs. But again, I think it's a very naive way of looking at this disease, as I'll show you right now. So we have this phrase in cancer surgery that biology trumps surgery. You know, you can be the best surgeon that you are or that you think you are or patients think you are, but the reality is the cancer really is the problem, not the surgeon's heroics, because the cancer outcome is predetermined way before the surgeon sees the patients. And as wonderful as Libby thinks I am, and I'm glad to hear that all the time, the reality is that many of us do Whipple operations with reasonable outcomes from a surgical point of view, but the cancer outcome is really the problem for most patients, not the surgeon or the patient. And this is just an example. I mean, these are the kind of differences we're seeing in what are called survival curves. This is a 400 or 500 patient study done in Canada where half the patients got the new drug called erlotinib and the other half didn't. And this is the way we do cancer research for the past 30 years. It costs millions and millions of dollars to do these studies where 200 patients get the drug, 200 don't. We then look at the outcome. It takes 3 or 4 or 5 years. And the problem here is that we're treating all the patients the same. And that's where I think the error is. And we're all kind of admitting this now in the era of what's called personalized medicine. This is another study. This was kind of the big splash 2 years ago. This is FOLFIRINOX. These are 3 drugs that have been around for 20 or 30 years. They're actually used in colon cancer. And a medical oncologist in France thought this combination might be useful in pancreas cancer, and it is. You can see there's a difference. Again, millions of dollars spent on a few hundred patients, randomized over many years. Half get the combination, half don't. A bunch do live longer and better. There's no doubt that's real. But again, the problem in my head is the fact that we're treating all these patients the same, and they're not all the same. So that's what I'm going to talk to you now. The last little bit is about genetics of pancreas cancer, and what we do know and what we don't know, and some of the scary lessons that we just found out really in the past 6 months since I was asked to speak. I said that I'm sure we'll have something to talk about, and we do. And some of those scary lessons are being understood, but again, it's worth explaining to you. If you look at any cancer, not just pancreas cancer, there's always environmental factors, and the most significant environmental factor in pancreas cancer is smoking. All the other stuff that you hear about is not nearly as strong as smoking. There are other risk factors like family history, which I'll talk about, and some other conditions like pancreatitis. And the association with diabetes is a little bit confusing, and diabetes is a risk factor, but it's not a strong risk factor. So the genome was decoded around 2000. There was a big celebration because the human genome had been decoded. But again, that was a bit of false advertising because we knew a lot that we didn't know, but there's still a ton that we don't know. And in those 20,000 genes, there's a lot that is predetermined in your fate when you're conceived by your parents, and that's called germline, what you're born with. And then what's called somatic, these are the changes that occur in the DNA while the cancer or while the disease is progressing. And all diseases we think have a genetic component that includes arthritis, diabetes, hay fever risk. All these things we think have a genetic component, but cancer has probably been the best study because the genomes are more available. We have tumors to look at, and there's been more effort invested in these tumors. And again, without going into the great scientific detail, in very many respects, your genome contains these 20,000 genes, and a bunch of them cause cells to grow, and a bunch cause cells not to grow. We call them oncogenes and tumor suppressor genes, and it is this fine balance in those genes that keeps you sitting here in reasonably good health. And you grow, and then sometimes your genes get a little bit abnormal, then eventually you develop a disease, maybe cancer, maybe Crohn's disease, maybe arthritis or heart disease, and then most of us, die before the age of 100, and a third of us get cancer. And in most cases, we think it's because of this imbalance in the function of these genes at some point in your life. It can happen at the age of 2, unfortunately, in a pediatric cancer, but in the case of pancreas cancer, it seems to occur suddenly around the age of 60 or 70 in most cases. Libby's case is a bit unusual because she had another genetic contribution that probably accelerated the risk of getting pancreas cancer. So Libby's case and others that my lab has been really interested in are called familial. I'm not going to talk too much about that, but the remainder of cases don't have a strong genetic contribution that we can figure out as yet. We think over time we will, but at the moment we don't really understand why the average person without a strong family history gets pancreas cancer. In the case of the familial form, so I took that 10% piece of the pie and now have turned that into another pie. And in that pie, you can see all the little fractions of diseases and genes that we do know about. And I'm not going to tell you all of them, but BRCA is one that's particularly interesting for a bunch of reasons, not only because Libby describes it, but because it has other therapeutic implications like it did in Libby's case. So we're trying to understand why these other genetic syndromes cause an increased risk of pancreas cancer, and it wasn't really appreciated until just recently. In Libby's case and others have shown that. And that's because, we named those genes the breast cancer genes, and that's the way it was since the early 90s, because those genes were found in breast cancer families. But in fact, there is increased risk of other cancers like pancreas cancer in those families. My own personal area of interest has been in other genes that we don't know. Libby mentioned the fact that we've been hunting for genes, and this particular family motivated me and others, and it's a tragic story of two young people in their 30s and 40s who both presented within 6 weeks of each other with advanced pancreas cancer, and their mother died of pancreas cancer, and their uncle died of pancreas cancer, and they don't have breast cancer genes or any genes that I showed you before, and we've been trying now for about 10 years. We have a paper finally coming out looking at what we call candidates, meaning there are some genes that we think might be contributing, but we haven't found the home run. There is no low-hanging fruit, and the other group that's working on this closely at Hopkins has found the same thing, and we're working with them. So we need, again, to step back and try to understand why this particular family developed pancreas cancer, has so many cases of pancreas cancer. We just don't know at this stage. But we do know, and there are some of the significant advances have been in BRCA-associated pancreas cancer, like Libby's case. This is actually BRCA1. Libby was talking about BRCA2. And this patient actually had a pretty big tumor here with a liver metastasis, and she got this tailored chemotherapy that we gave Libby and we've been using for the past few years. And her tumor actually melted away, as did the liver metastasis. And we actually operated on her, but unfortunately, the cancer came back a year later and she actually died of her disease. But she did have this interesting response. And again, these are just little signals, little rays of hope, I guess, to put it in perspective for the symposium, where we are seeing things that are the result of understanding the genetics. We don't have the cure. Patients, I get emails from people all around the world thinking that I have something that nobody else has, but the reality is, we do share this information broadly, and everybody now in the field is looking at gemcitabine, cisplatin, PARP inhibitors in the BRCA patients, and it's not a one-to-one relationship. Libby's case is unusual. We have many other patients with mutations in those genes who are not sitting here and have not responded nearly as well, and that's kind of where we need to start thinking more carefully. Libby mentioned this study that we did in the past couple of years, and this has received a fair bit of press because it's a great study that we did at Princess Margaret. And again, this is expensive work, which is why we need more research funding. We simply took 300 consecutive patients that walked in the door at Princess Margaret. We didn't select them by any specific criteria, and we offered them BRCA testing on a research basis. And we were quite surprised that we found that 14 of the 300 actually had mutations in those genes. And in most cases, those individuals and their families actually didn't expect that and didn't know that. It has broad implications for the remainder of the family, in particular the children, who are at 50% risk of having the same mutation that's in one of their parents. So again, it provides a lot of new information. Some people don't even want to know this information, so our genetic counselors are pretty busy with this field. But again, we published this, and it's received a fair bit of press because a 5% rate in the average major cancer center like Princess Margaret is a pretty high rate when you think about it. So again, especially if there's going to be implications for treatment, which I'll talk to you about. So this is just one study that we completed. This is kind of a simple project, but it was a necessary project because people just didn't believe this association until we did it in a very comprehensive way. This is one of those families, one of those 14, a woman from the Philippines, actually a man from the Philippines. Squares are males, circles are females. And what's interesting about this family history, these are the parents, these are the grandparents, is there's no other cases of pancreas cancer. So this is a BRCA2 mutation carrier who doesn't have a strong family history of cancer. So again, the whole definition of BRCA cancer genetics is being changed now that we've made this association, because in the early 90s, when those genes were discovered, they used a lot of really strikingly strong families to identify the genes. When you're looking for a gene, you want to pick the best families. Once you find the gene, you then want to broaden it into the general population. You find that people all around the world who don't have family histories actually are carriers of these various genes. So that's one lesson. The other lesson we've learned is that there's something called Lynch syndrome, which is hereditary colon cancer. And some of these Lynch syndrome families, who again think that they have hereditary colon cancer only, also have a higher risk of pancreas cancer. And what's particularly interesting, again, just in the past 6 months, is that these families and these subjects, which are rare, albeit they're rare, have a really high response rate to the new immunotherapies. You hear a lot about immunotherapy, and it looks like this particular subset, which is tiny, will probably have a really good response to immunotherapy. We're actually looking for a patient within our center. We think we found somebody, and we may be able to offer them immunotherapy. They actually have fairly advanced disease, and we'll see what happens. So I've been heading what's called PanCure, which again is your tax dollars at the Ontario Institute for Cancer Research, which is on the Mars building at the corner of University and College. And this is actually a pretty broad-based program that has international collaborators to try to really dissect the genetics of this disease, and I'll show you some of our work. Again, this yellow thing is the cancer that's been removed from somebody. It looks pretty big. It might be 3 or 4 centimeters. The problem is, under the microscope, this is one of the worst diseases to study, why it's lagged behind many of the others. All of this stuff, this is a microscopic picture, is just inflammation and pancreatitis, which is one of the theories why drugs don't get into pancreas cancer. It's a simplistic view. Something that we're studying is because there's a lot of inflammation and what's called stroma, which is fibrous tissue, which may be preventing chemotherapy from getting in. So it's a whole broad field of study. These are the cancer cells, and there aren't that many of them, and it is quite mysterious how just a few cancer cells within that tumor can spread widely, again, in most patients, 8 out of 10. But you can imagine when you're doing genetic work and trying to extract DNA or RNA or protein from this blob of tissue, in most cases you've got the DNA and the RNA and the protein from the stroma, from the inflammatory cells, not from the cancer cells. So it's taken many, many years for our pathologists and their technicians. It takes a whole day to dissect, and they actually do it the way I'm doing it with this laser pointer. It's called laser capture microdissection. They look through a microscope, and they have to actually outline like this. And then they push a button, and there's a special knife that pushes those particular cells into a little test tube. But there might only be 50 or 100 cancer cells here. So you have to do multiple sections. It can take an entire day just to do one tumor. Again, why this field has been so difficult from a technical point of view. So we've kind of overcome that. And again, this shows you the magnitude of the work that's being done just at the OICR. These are trillions of base pairs. Base pairs are the ACTG of DNA, and 120 trillion base pairs have been sequenced from a couple hundred tumors, but it's taken us this long to enrich the material so that we have really high quality DNA for our research. And this is what's called the first pass through the genome. And this was actually published probably 3-4 years ago in collaboration with the other group that does this work in Australia who moved to Scotland. And so our collaborators on the international front are actually in Scotland, and they're doing almost the same thing with us. They're collaborating and competing. It helps to push the field forward to actually compete a bit, but of course we try to share the data as best we can. One of the most staggering early findings, these are actually a bunch of genes, and each of these lines is one case, so there's 150 cases, and it looks a bit confusing to you, but if you just sort of focus from here up, it turns out there's only 4 genes that are mutated in this particular cancer, and that's particularly unusual. That was the first thing we found a few years ago, is that this is called RAS and P53 and SMAD4, and this is called CDKN2A, or it has another name called P16. But the sad thing, and what's the scary thing, was that we knew about this in the 90s. We knew that pancreas cancer had RAS mutations and P53 mutations. What we were hoping is that if we had this really deep sequencing of these high cellularity tumors, we'd find new mutations, but we didn't. So actually that was the first lesson that was uncovered just a couple of years ago, is that the type of genes that are mutated is no different than we thought about in the 90s. So in that case, why is this disease so lethal if in fact it only has mutations in about 4 genes? And these genes are mutated in many, many other cancers as well. So then when you start putting these data together, you start finding what are called networks, meaning you have a couple of rare mutations and a couple of common mutations, and you start finding what are called networks or pathways. It's not just one gene that's mutated. Commonly, you might find a RAS mutation and then a less common mutation, and they start generating what are called networks. These are pathways. So these are all the different pathways that are abnormal in pancreas cancer. So you can imagine that if you're a drug company or a scientist and you want to come up with something clever and new, you might pick this one or this one. The problem is the cancer cells are very smart. There's a lot of what we call redundancy, and even if you knock off this pathway, some of the other ones will take over. So, and again, you can't target 7 pathways in a patient. You can't give a patient 7 toxic chemotherapies at the same time. So again, another kind of scary lesson that we've learned in the past few years. The other interesting feature, which is something new that we're only learning now with these new genome technologies, is what's called polyploidization or multiclonality. And this is, again, is kind of breaking a paradigm that you heard about when you were in grade 9, that cancer is kind of a disease of evolution, that one cell becomes abnormal, then it grows, develops an evolutionary advantage, and then it spreads, and then that one develops another evolutionary advantage called clonality. But in fact, when we look at these tumors, we see that there can be 2 or 3 separate clones that are completely different from each other. And even if you knock off one, the other one might take over. And this is, again, a paradigm shift in the way we think about cancer. And the same thing's being found in prostate and breast cancer, and probably explains a lot of drug resistance. So you can have a patient with a BRCA mutation, give them the same drugs we gave Libby's, gemcitabine and cisplatin. It looks like it's melting away, but then 6 months later it's growing, and that particular clone is resistant. And it's been much more evident now than we thought before, again, just because we're sequencing in much greater depth than we ever used to. And this kind of is the final kind of grand slam of what we found, and we're trying to get this published. Much of this work has been done by a postdoc named Fayez Nota, and I won't go into all the details, but this is a concept that's been around for about 5 years and probably explains this disease better than anything. Because I just told you that there was only 4 genes, and we knew about those genes since the 90s. But with these new genome technologies, what we're finding is we can look at what are called rearrangements, the number of chromosomes, copies of chromosomes, how the chromosomes have been interacting. And in fact, there's this phenomenon called chromothripsis, which is Latin for shattering of the genome. So what happens is the chromosomes break apart, and they actually get rearranged in very abnormal ways, in ways that we never even thought about till just about 5 years ago with the resolution that we now have. And this concept of chromothripsis was described in breast cancer and other common cancers where there were more tissues. But in fact, in pancreas cancer, which is called PDAC here, the rate of chromothripsis is actually 70%. It's a staggeringly high level and much higher level than in any other cancer. We're just trying to get this published in some of the major medical journals just to kind of bring it out to the audience. And what we really need to be doing is understanding why this happens. This is going to be next to impossible to target pharmacologically with a drug. There's no drug that's going to fix the genome of these tumors that are so abnormally rearranged. What we really need to understand is why it happened, what's the outcome, and how we can go about studying it and treating it. And again, this is one of the scary lessons, and I don't mean to scare you, but this is it scares us looking at these genomes. So what we've done, and I really want to highlight again from the fundraising perspective, and just to emphasize what PCC and others have done, is they've taken a disease that no one talks about and people generally die from very quickly, and made it more of a household name in Canada. And Canadians actually are appreciating the work that we're doing and the frequency and lethality of this condition, and the fact that even though I've told you that things aren't looking too good scientifically, there is a lot of hope just because of this new knowledge is going to lead to a breakthrough. I'm pretty convinced, and it may not be my brain, but I'm sure there'll be some other people in our group and other groups around the world. And really, we just need to accumulate all this new knowledge to make progress. So what we've done, what I've been trying to organize in the past couple of years, is a multidisciplinary team. At university and college, we've got the major medical centers, Ontario Cancer Institute, Mount Sinai, Lunenfeld, Sick Kids, and UHN, who all work together. For the most part, we have separate foundations for good reason, and we're always trying to raise funds for this work. But in fact, at the ground level, or what I call the blue-collar level, where I like to think I am most of the time, we have a lot of really passionate people who want to work together. So we assembled this team, and it's funded by the OICR, where I also one of my jobs. So again, it's a government agency, so we're responsible to you, to the public, and it's called PanCure. I didn't come up with this name. It was by Tom Hudson, and the X is silent. And there were some IP issues with names, so it's always hard to come up with a new clever name, but that's the name that we are. And we actually represent a whole team of individuals from all of the hospitals and the research institutes at the corner of college and university. And this kind of just shows you the magnitude of the kind of work that we can do. This is the top thing I showed you that was 5 years ago, just what's called the coding mutations. Down here is this really new genetic data of the genomes, and you don't have to be a scientist to appreciate these colors. And each of these colors, or each of these vertical lines, is a case, one of those 150 cases. And it costs about $10,000 to do a genome. Now we can do it for much less, but it did cost $10,000 when this work was done. So again, this is an expensive way to do science. But what's interesting is you do see patterns. So this group here, with a lot of light blue, are actually the BRCA cancers, and they look quite a bit different than the others. Then there's these other guys over here where there's one of these and one of those and one of those, which look different than all the others. So these are what are called subtypes. So what we're finding is that there are subtypes of tumors, and this is the same way it's being done for every cancer, almost every disease. And you look on the wall of PMH, it says Y is in our DNA, and that's what I believe too. And if you're a drug company or a medical oncologist and you want to do a study, why would you take all the patients, throw them into two groups by the computer, flip of the coin, give half the drug and other half the other drug, and expect to see a grand slam? And that's kind of where we've been doing it for 50 years. So we really need to think differently, and that's kind of where we're at now. We need to subtype where we can, and then pick off the patients who are more likely to respond to a treatment. You don't need to be a scientist or a doctor for this to make sense. I mean, it makes perfect sense to everybody in this room, I'm sure. But in the case of cancer, it's been difficult to do, and now I think we're at the stage where we can do it. So some of these patients are like Libby's case. In fact, Libby might be one of these patients. I can't remember. And we're looking back at whether some of them responded or they all responded. In fact, they do generally respond better to special chemotherapy. They may respond better to any chemotherapy, not necessarily just to those two drugs. So there's a lot of controversies whether you need to give them these fancy, expensive drugs or just give them any chemotherapy. The mice that are growing with those tumors from the BRCA patients actually respond to gemcitabine, the 25-year-old drug, almost as well as they do to the platinum. So again, we're starting to step back and wonder, what are we really dealing with? And then also, just because they look all the same to you and me, they probably are different and there even is more subtyping that needs to be done. This is just the genome, and this represents a small portion of the variation in our bodies. There's other components of our DNA and RNA and protein that we haven't even scratched the surface, and we're just starting to do that now. I'll leave that one alone. The other thing that we're doing at PanCure is all the data that I've shown you and all the published data are patients whose tumors were removed by surgeons. And that's because they were available to scientists because they're big. And we need big tumors to microdissect those little cancer cells that I was showing you. But in fact, 80% of patients aren't operable. And one of the questions that we've been criticized fairly by the scientific community and the grant funders is you're only studying 2/10 of the problem. You need to look at the other one. So we've actually started looking at patients with inoperable cancers by getting biopsies. And then I'll show you at the end this exciting project that we're about to start, which we're only going to be studying patients with advanced disease, with liver metastases. But just the first pass through the genome, comparing 148 operated cases with 20 big tumors that we couldn't remove, so these patients were not operable. If you look at the genomes, we're not seeing any difference. So it's reassuring to think that what we're seeing in that, all that effort that we've been doing in the resected or operated cases probably can be extrapolated to all patients with even inoperable tumors. So that's actually rewarding for us and for the community to know that at least we haven't been looking at the wrong subset, and all of our papers and work that we've done has been that little piece, and they're so much different than the other piece. Although it would be naive to think they're that much different anyways, we just need to prove it. So this, again, don't worry about all the details. It shows you the kind of work, the project that we're doing, and it involves clinicians and scientists everywhere on the street there. We have mouse models, we have tumors from patients that live forever. The mouse models live forever. They're growing in mice, and we can put them into another mouse, put them into another mouse, put them into another mouse. This is work that David Headley's doing, and we can actually treat the mice with chemotherapy. And there was a big paper that came out last week by, I think it was Novartis, one of the big drug companies. They spent about $10 million. They took hundreds of different mouse models of all the different cancers, and we can do screening tests. Now, we can't grow a mouse model any faster than 3 or 4 months, so we can't really help any particular patient. But by studying these subtypes, and this is the BRCA subtype, we can actually learn a lot about those specific subtypes in the lab. So that's one of the projects we're doing. The other project we're doing are what are called organoids. So you take a tumor out of a patient, you chop up the cells, and you dissolve some of that stroma that I was telling you about. The cells grow as little circles, what are called organoids, and you can actually treat, these can grow right away, and they represent the disease more closely than the old style of what's called tissue culture, and it's much faster than a mouse, which takes 3 or 4 months. So there actually are projects underway at PMH and elsewhere where we're going to be removing tumors from patients, growing them as organoids, and testing them with chemotherapies over a few weeks, and hopefully be able to pick a chemotherapy that's right for the patient. And then finally, this is what I think what we're the most proud of, and it hasn't even started yet, but it took us about a year, or it took us 2 years to develop this project, and I'll just take you through it quickly. It's called COMPASS. Every trial has to have a name so that everybody can talk about it. You can't just say the study or the pancreas study. So we came up with COMPASS, and I can't remember what it even stands for. One of our fellows came up with its comprehensive something about pancreas cancer. So we call this COMPASS. And it's a really bold study that we're about to undertake, because everything I've shown you and much of the published work, and even papers that came out last week, are groups of patients with genomes, with data. And a lot of that data was collected backwards, kind of retrospectively. The patients weren't on studies. The medical oncologist may have had something in mind, and we wouldn't know that. The patient may have had something in mind. So these are retrospective studies that really don't provide as much information. So this is actually the first prospective study of a genome and targeted chemotherapy. So we're going to actually recruit patients with advanced disease. So everybody in the study will actually have liver metastases, unfortunately. So people that come into Princess Margaret will be identified at our McCain Pancreas Cancer Clinic. And if they have a large enough metastasis in their liver, then our radiologists will actually biopsy that metastasis, and they get 4 or 5 little cores, and those cores are the size of a pencil lead. And we're then going to process them immediately. In the background, in the foreground, the patients will then be treated with the 2 types of chemotherapy that we treat patients with in 2015 at the choice of the medical oncologist and the patient. So they happen to be today FOLFIRINOX. Is it even up here? FOLFIRINOX or Abraxane. And again, that decision is made by the medical oncologist. So the patients will be treated for 8 weeks. And the challenge to the genomics team that I'm representing is we've said to them, we need you to provide a genome in 8 weeks. Not a research, well, it'll be a research genome, but you can't take your time, you can't drop the sample. People can take holidays like they normally do, but you have to have a clinical grade genome, and that hasn't been done before in a large scale way, because this is not a high throughput system yet. It will be in 20 years or 10 years, and we'll be laughing at this study, but at the moment it really hasn't been done on a clinical basis. So what will happen is at 8 weeks, then the genomics scientists will tell the medical oncologist, well, your patient has this pattern, and they'll be like those patterns I showed you, those colored boxes. And we're going to see patterns that we think are meaningful, and we're then going to treat the patients based on that pattern. Hasn't been done before. And we'll be able to see prospectively if, in fact, a lot of these predictions are right. And what's more importantly is that we're hoping in the next couple of years, while we're doing this study, there'll be new advances that'll be made, and we'll be able to engage patients immediately into these studies. So again, this is what we call COMPASS, and we're trying to recruit 180 patients over 4 years. And then on the right here, it's a bit ambitious, and our fellow came up with this kind of cool slide. And what we're arguing is that every patient will have a personalized approach. I think it's a bit naive, but we're hoping that there will be groups of patients for which we can actually take a drug, call a drug company, do something that we're doing differently than had they not had their genome tested. And I think, in fairness, I'm going to stop there. I'm happy to take a couple of questions. It's very hard to make acknowledgement slides these days because it would just be hundreds of names. This is an old slide. I need to update it, but I could put hundreds, literally hundreds of names, because the collaborations extend throughout the province. We're now working with a group in BC doing a similar project. We've been working with the group in Australia who are now in Scotland. And there's a lot of scientists that are involved with this work. It's not easy work, and we do try to break it into chunks that we can handle in terms of writing grants or explaining it to people or having a student or two on the project. But it takes a lot of people and a lot of money to do this kind of work. And of course, we're always grateful to PCC for what they've done. It's now 11 years. Is it 11 years? 10 plus years. And the association for me has been terrific. Libby and others are inspiring, and I think there is a lot of hope. And I hope I've shown you it's scary for sure, but there's a lot more that I'm saying today that we couldn't say a year ago and 2 and 3 years ago, and I'm sure next year there'll be hopefully even more. So thanks for your attention.